beer stein that we give all of our speakers, and as pictured here. And the paper of the month, and if you'd like to capture this, just please go ahead. It's by our presenters today, which is entitled Development and Validation of an AI-enabled digital breast cancer assay to predict early-stage breast cancer recurrence within 6 years. And this was published last year in Breast Cancer Research. So our two speakers today, Michael Donovan and Geraldo Fernandez, are physician scientists that have straddled the landscape of both academics and startup and the pharmaceutical industry for quite a while. They have lengthy CVs that go back between quite a few companies and different academic affiliations that just for time, I'm not going to go through in detail. But if you guys want to highlight any parts of your background, please feel free to. So thank you very much, and we look forward to hearing about your morphology feature array.
Great. I will share my screen.
While Jerry's doing that, so we're going to be tag teaming the presentation. So I will go first, and then Jerry will follow, and then I'll come back. So we'll be back just to try to mix it up a little bit, but happy to be here to present some of our data with regards to breast cancer risk assessment tools.
All right, set.
Can everyone hear me okay? Can you hear us? Yes. Nod, yes, good. So Jerry, you can probably move on if you want. So the idea really, and just as, thank you for the introduction, that was very nice. So both Jerry and myself have been in the predictive medicine, personalized medicine space for quite a number of years, myself a little over 20 now, and using various tools that encompass both machine learning as well as digital to be able to bring these types of applications forward. And part of that effort has been driven in one level of being in the precision medicine space and understanding the necessity of that, being pathologists, and understand the challenge of that. And as this slide illustrates, there is obviously, as many of you are probably on the call, if you're pathologists, understand there's a pathologist shortage, which is both within the United States, Europe, as well as in China. So there's significant challenges of bringing pathology and pathologist expertise to the general population, because the diagnoses continue to be made, yet the pathology side actually is, in terms of it's decreasing. There are accuracy challenges overall, as many are aware, with regards to the idea of diagnosing whether it's cancer grading systems or disease processes, inflammation, that there are and exist diagnostic fatigue, and with that will emanate sort of inaccuracies in terms of that ability to be as accurate as possible as pathologists, which is really what our mission is and our goal. And so specific things like mitotic counts and distribution of lymphocytic infiltrates, things like that become challenging at the, if you're looking at multiples of cases every single day. So there's an accuracy piece there. And then obviously one of the goals for us is to take it out of the subjective piece, because as pathologists, we're very much in that zone of being opinion-based with regards to what our views are as you're looking at something under a microscope. And that lends itself to a number of challenges with regards to both, one day you may change your particular view of something, and then that can be different from a pathologist who you work with or a pathologist in another area. And you can see how that would impact even on overall patient care. So from all those variables, there are understandable challenges within regards of this space. And how do you develop tools to really support the pathologist in this process, support the oncologist in this process as well, as we're focusing on breast cancer was our mission. And on the next slide, so taking that consideration of understanding what that looks like, we're going to focus today on breast cancer. And, for us, we've worked in the prostate cancer space for many years and quite visible. But with that has always been the understanding that breast and prostate cancer go hand in hand for a number of ways. And breast cancer itself has surpassed lung cancer, as many are aware, as the most common diagnosed cancer worldwide. And with 290,000 Americans diagnosed breast cancer in 2022 and 43,780 will die of their disease, it's really a significant problem with regards to how to actually influence the overall progression of disease in the context of an individual patient at the time of diagnosis, because those numbers are quite large. Now, our guideline systems support both the pathologist and the oncologist are looking at this from a clinical practice perspective, and that's the NCCN, ASCO, and CAP, have very distinct guidelines, especially with regards to breast cancer, for using a comprehensive pathology assessment. And that consistency is needed to be able to introduce this into a standardized way of managing patients. The challenge is, and it's noted in the NCCN guidelines, that pathology reporting is not consistent, and there are challenges with regards to not having grade, not having margin status included on a large number of pathology reports, and even synoptic reporting is not, even though it is mandated, is not readily used across the entire United States or even in Europe. So there are challenges with regards to managing those guidelines and how can we influence those. And then obviously over the past several years, to many years now for some, there's a number of genomic tests that have and support that entire management process. Obviously the most visible have been Oncotype and the MammaPrint. Oncotype obviously has been out for quite some time and has been well vetted with regards to large numbers of patient populations, to have that understanding of how to influence as from a predictive perspective with regards to treatment indicators like endocrine and chemotherapy in the context of that group. Whereas others are more risk-based approaches. And if you look at the evidence associated with them, you have the larger bucket, which is really these risk assessment tools, which incorporate a variety of parameters that Jerry and I will speak to today that led us down this path of how can we influence this entire approach and make it standardizable and accessible to broadly across the population of patients that are being diagnosed with breast cancer. And so on the next slide. So this issue obviously is quite discrete with regards to how really the selection of proper treatment is influenced by that genomic strategy, but it's also influenced by that mandated pathology assessment up front. And there are a number of new diagnostic developments and technologies that have been brought to bear in this, but many of them have been challenged with regards to really play a direct role in what happens to those individual patients. So despite some of our innovative approaches, it still doesn't really impact on some of the very important variables like overall quality of life and things along those lines. And so there's a necessity in this entire approach to breast cancer is this accuracy and timely risk assessment become very important to influence the survival rates, to influence that driving of the decision process of how to use the information that's at hand. And it's really to maximize the information that's present in the invasive breast cancer from a phenotype perspective, from a grading perspective, and that becomes part of that adjunctive source in concert with the genomic studies to actually influence the treatment and obviously overall outcome of those individual patients. And so we'll take you through some of where we've been with this in mind. And Jerry, if you want to go to the next slide. And with that, there are pros and cons of what's out there now in the genomic testing and even in the machine learning space in the context of risk assessment. In the genomic testing, they're accurate and they're objective, but there are considerations with regards to the high cost associated with the individual genomic assays. I don't know how it is in Hawaii, but there are obviously not all distributed healthcare systems can actually absorb the costs associated with the individual genomic testing platforms. There's risk assessment, understanding, try to how to use that from the provider side. And then obviously a very practical end is there sufficient material to be able to run the genomic test? And that'll always be a consideration as we end up having some of our advanced screening tools, mammography and other approaches, tumor sizes will be smaller. And so will there be sufficient material to run genomic tests on? And that will always be a challenge in that setting. And on the flip side, from machine learning approaches, which there's, I think there's very good reproducibility in that approach. And that's why there's been a push in the AI space to help in identify cancers that are present within a biopsy or present within a resection specimen to help facilitate that. But they still are challenged in terms of how to introduce these into our existing platforms, especially in the pathology setting. And will they just be an effort to identify cancer, or they help to go beyond that? So it's really been a focus on just disease detection and not so much on risk assessment from the current AI tools. And there, for some, it is a black box. And so there's uncertainty from the pathologists of how to actually use these kinds of materials. So two big buckets of areas that have advanced the field, but with all pros and cons associated with them. And it's just something to always keep in mind as we move through this approach. So now I'll turn it over to Jerry to take through the platform at PreciseDx, the morphology feature array, and how we develop what we're actually going to share from the clinical side as well.
So thank you, Michael. So we set out, actually we started out quite a few years ago in the fluorescent, multispectral immunofluorescence space, trying to characterize tumors and provide morphologic and biomarker data to help guide patient treatment. But in 2015, when AI became really a viable option, we switched gears a bit because of the difficulty in scaling multispectral immunofluorescence. We started to take a look at, well, how can we leverage the information that's in an H&E stain slide using AI, and we started building models with the output to some of these networks that we were building, and we found really in the earliest days that that just with the information present in the H&E stain slide, we were able to build predictive models or prognostic models that competed favorably with markers with models that included biomarkers. So pretty much that settled it. Just from our perspective, we switched pretty much and focused primarily on H&E stain sections and trying to extract as much morphologic information and spatial information from the H&E stain slide. So in breast cancer, well, so we, the typical view of artificial intelligence in pathology really is more focused around this black box approach, where you take large amounts of training data and you ask a question, and if you have enough training data, some of these questions can be answered, can be predicted, but nobody knows exactly what goes into the output of the network. So you learn to gain faith in the results, not so much because you understand what the black box is doing, but you gain faith in it simply because of the numbers of cases that you have. We took a slightly different approach, and the term explainable AI gets thrown around a lot these days, and we throw that term around for our morphology feature array. To be truthful, all AI is a black box. There's no such thing as not having a black box. Every neural network is a hierarchy. I'm sure there's plenty of engineers on this call that understand this. The layers in between in the neural networks are not explainable. The reason why we call it explainable AI is because we use the AI to categorize objects in the H&E stain slide that are recognizable by pathologists. So we're able to essentially quality control and the output of all the different neural networks. So we develop a handful of networks that we use in combination to generate about 10,000 or so features. And from those features, we're able to then, using a separate layer of algorithms focused more on support vector regressions, to generate a risk score with the best combination of those 10,000 features. So this is a schematic that roughly explains this. So the input image is an H&E stain slide. And then we have these series of smaller neural networks, which we call building blocks. And then the output of every one of these neural networks is confirmed visually by pathologists. And then the output then either individually or in combination with the output of other neural networks combine to form these 10,000 or so features. We've picked, I'll show you in the next slide, we picked 7 of those and put that into our risk stratification engine, which is a support vector regression for sensor data. And then that's the final output of our assay. So it's really 2 layers. One is a traditional deep learning layer down here. And then up here, there's a more of a machine learning approach that actually creates the risk score. This is another view of the same process. We call these 10,000 features our morphology feature array. And it is the combination of all the building blocks and all the different permutations that are that we can derive from the building blocks. From that, we go through a feature selection process. In the case of breast, that feature selection process is based on the univariate performance of each individual feature in our cohort, in our training cohort, which we use the CI, to evaluate features that are likely to contribute positively to a model. And then we also apply a domain expertise filter to it as well. So we're not really in the business of finding new features, although sometimes we do, and it, we have to, our goal is to commercialize a model that will be accepted by pathologists and oncologists. And so, there's a bunch of different features that can be derived from the morphology feature array that may not exist in the literature or that may not be commonly recognized as being prognostic features. So we're pretty careful about not going down that path for a variety of reasons. One is because we want our models generally to be, for people to look under the hood and recognize what is going on and accept it from that perspective. But there's also the danger of overfitting and getting caught in a place where you've selected a feature that fits nicely in your cohort, but when you try to scale the model to a different cohort, then that feature may not perform as well. So for those reasons, we really try to stick to features that are recognized by pathologists as being legitimate prognostic features. So in this case, we narrow it down using both the CI concordance index and the domain expertise to about 100 or so features, and then we build we iterate the models over and over and over again until we find the best combination of features. And also, to be clear, in this feature selection process, we also include clinical features. So so it's a combination of imaging morphologic features and clinical features that go into this phase, into the support vector regression models to generate the best performance for risk stratification. So using this approach, a few years back, we won the Bach Breast Cancer Histology Challenge. Actually, there was 2 parts to this challenge. We came in first in one and in second in the other, but I think a few years after, they keep posting the results because people submit after the challenge has closed. The person who was in first place for some reason dropped out. We're not entirely sure why, but so we are the overall performance leader in that challenge so far as of January of this year. So our building block approach focuses on a few different layers. We focus on generating a specific region of interest. So that optimizes the performance of the model, of the runtime for the algorithms. So we try to ignore sections of the slide that are not relevant to prognosis. And so in this case, as you see here on the top right, we end up excluding dense fibrous tissue and fat, so that the algorithm only has to run on a specific narrower region, and that helps us optimize the run time for these models. We also do stain normalization. We do take two different approaches. We perturb the images as they go in, so that we have a variety of different staining parameters that get trained in the training phase, and then also on the when we receive a new specimen that's going in, we adjust the staining, the color and staining parameters of an incoming slide to a reference image, which we've used to essentially normalize the staining characteristics across our entire cohort. So we do, another building block is the epithelial detector. That gives us a compartment which separates epithelium from stroma, and the nuclei compartment then helps us create 4 different compartments. So epithelial nuclei, epithelium, stromal nuclei, and stroma. So we're able to use all of these 4 different compartments to generate features. And then finally, mitotic activity, which is important, obviously, in oncology to grade the severity of different tumors. So from these building blocks, these are just 4 examples of the types of features that we generate. So the mitotic figure detector, you have a low and a high, low on the left and a high on the right. Mitotic figure detection by itself seems like it could be one feature, but it really generates multiple features. There's a variety of ways to look at mitotic figures. There's we have recreated the 10 high power field feature in the Bloom-Richardson grading system, where the detector identifies the 10 high power field region that has the most mitotic figures and counts them. You can look at just the plain old distribution of mitotic figures with a denominator of epithelial nuclei, or you could look at distribution of mitotic figures, the heterogeneity or the homogeneity of this distribution of mitotic figures throughout the tumor. Gland morphology on the top right. This is obviously also based on the Bloom-Richardson grading system, where we look at lumen formation and ring structures. We also look at all the different types of morphologies, sheets, trabecula, cords, single cells, and characterize them and each tumor has a characterization of these different morphology subtypes. Nuclear pleomorphism assessment on the bottom left. In these images, you can see that on the left-hand side is a high nuclear pleomorphism, and on the right is a low. And again, this feature, on the surface, we look at nuclear size, but when you look at the nuclear size of every nucleus in a tumor, you're able to do a bunch of different things with it. Look at different ratios of size. So in this case, and in our model, we have the larger nuclei, which are in red, as the numerator, and the denominator is the average nuclear size in green. So in this, you can clearly see that the ratio of large nuclei to average nuclei is higher on the left than on the right. And then finally, tumor infiltrating lymphocytes. We use a lymphocyte classifier detector and classifier, and then restrict the counting of lymphocytes to a region that's a peripheral region around the invasive epithelium, which is recognized as geographically as the most significant region of lymphocytic infiltration. TILs. So that's another feature that has a nice weight in our model. So one thing that we're probably not going to get into very deeply, just because it would take a lot of time, but we submitted our we published the paper in Breast Cancer Research last year. Was our clinical validation study. We also did a very comprehensive analytical validation study, which we submitted to New York State, and earlier this year got approval from New York State to run the test in our CLIA laboratory. One of the tests that we did, among many, was a stain variability study. So where we were able to grab a cohort of patients and stain them at the University of Columbia and at the University of Pittsburgh and in-house. And we compared those, Columbia to in-house and Pittsburgh to in-house. And as you can see, the slope here is pretty impressive. That the staining normalization approaches that we've taken really render, within sort of normal staining parameters in the United States. I know things can get pretty crazy. Everybody has seen staining that is really outlier type staining, but if it's really generally within the standards that we accept here in the United States, staining parameters really don't affect our model very much. So I'll pass this back on to Michael to describe the clinical implications of the model that we developed.
Thanks, Jerry. So as everyone sees, sort of where the emanation is for the features that are being derived from the invasive breast cancer. And through efforts at Mount Sinai, where both Jerry and I were, we curated all of their breast cancer cases from 2004 to 2016. And that's a 2,075 patient cohort, which we then divided into a training and a test set. So this was a 2/3, 1/3 split to be able to construct and understand those features that Jerry just went through from the morphology feature array, the role that they play or not with regards to creating an optimal model that was associated with recurrent disease. And our approach was to looking at this over a median 6-year follow-up and with a composite endpoint that was designed to understand recurrence of disease, both local regional metastasis and overall survival. And that was the essence of this early stage understanding of recurrent disease within the population, within a single healthcare system, with a fairly large number of patients. The next slide. So our intended use with regards to the test is as an in vitro prognostic assay for patients with early stage invasive breast cancer. And that was really to put it into the context of where our approach is, and that significance is really within that early stage piece, primarily because that was the largest population actually that was present at Mount Sinai. And we're using the features that are derived from digital features that are present within H&E sections of breast cancer. So that helps to sort of understand and frame it of what is accessible from the tissue side, and then incorporating readily available clinical features such as age, tumor size, stage, and lymph node status to actually construct a model, which I'll show you the results from, that actually we're identifying the appropriate use and balance of clinical features that are readily available from the clinical pathology service, as well as then features that are present within the H&E section, and bringing those together to construct these models. Next slide, just to give you the demographics of this group to really reinforce that, and because we pulled all the cases, so this was not, it was really a longitudinal collection, not really selective. And median age was 60 years. There was 55% Caucasian, 25% unknown, and 5% African American. That numbers are pretty much, we see now by going through the cohort studies at Mount Sinai that the African American Black population is actually much higher than this. 87% were ER positive, so you can see the numbers for ER positive and PR positive, so majority were actually hormone receptor positive, and 88% were HER2 negative. So again, sort of that concept of early stage, really well-differentiated tumors. 75% were T1, so this is going through the size, and then you can see the distribution of the T2 and T3, so fairly, again, early stage disease, and then 68% were stage 1, 24% were stage 2. So that's your largest groups that any of those genomic strategies would actually be focusing on in terms of an outcome perspective. and then 8% stage 3 to 4. The 69% had negative lymph node in terms of like negative positive lymph nodes, when 31% had positive lymph nodes, and then 15% of those were 0 to 3 positive nodes. And then that look at the grading system that was used across all these years. And so 14% were grade 1, 42 grade 2, and 44 grade 3, which is pretty common of a distribution with regards to the characterization of the biological potential from a grading perspective. And then again, this early stage and group, 14% event rate. So that's obviously reflective of the population I just described in terms of the stage and size. And this is followed for a median of 6 years. And so the way that our models are constructed, as Jerry went through, we look at this from a variety of evaluations in the context of individual features, and they're all outcome-based, so they're driven by that particular feature and its appropriateness to be able to predict the likelihood of recurrent disease based on that composite endpoint. And that's an iterative process that goes through looking at thousands of features to reducing it down to a subset of features that are associated in a context of a multivariate setting to predict outcome. And I know this is a lot of information on this slide. This is actually within the paper as well. And it encompasses both the training and the test set data. So as you use their training set data to identify the population of features as well as your clinical variables. And you can see the CIs are 0.78. So quite good from an AUC CI concordance index perspective. And then you see the sensitivity and specificity there. And then in the test set, so that 0.78 goes down to a 0.75. So also quite good in the AUC CI modeling space with regards to that prediction of a specific endpoint. And I will add that, when you can see there's clinical data as well as features in the bottom half of the slide here, and that gives you that differential weighting of the individual features, including the clinical variables and how important they are as they play with each other in this multivariate setting. And just highlighted the two in yellow, which have the highest value and also are different signs. And you can see as Jerry went through that tubular formation, so the context of a well-differentiated tubule, as a 42 with regards to the context of as you weight these differential features is quite strong. Well-differentiated tubules, better outcome, as opposed to the positive lymph node, which is really a measure of the amount of lymphocytic infiltrates that are actually present within the tumor. Not present within the tumor. So that differential there is a negative, which means that the less number of lymphocytes that are actually present within the tumor, the worse it is for the patient, because you can imagine conceptually that lymphocytic infiltrates, especially intratumoral, will actually be a positive in terms of the overall reduction for recurrent disease. So you're able to pull together fairly complex models that take both the features, clinical as well as imaging, and pull them together to be able to construct an actual outcome and a risk score for an individual patient based on a threshold. So, and I'll show you some of what that looks like as we go through the AUC curves, as well as then getting into Kaplan-Meier's, how that can be used clinically as we stratify patients based on their level of risk as being low or high risk for recurrent disease. And when you do these kinds of approaches, we look at it from a number of perspectives. So this is a combination of both the training and test set data that I just went through, the full model, which is imaging plus clinical features, that 0.78, 0.75 that I shared, as well as we have the confidence intervals on here as well. And then if you look at that from an imaging only model, 0.72, so quite good. And a clinical model, 0.71, also good. You can see that clinical features are important, as we all know, in the context of understanding the potential for breast cancer. So size and lymph node status are important, and those are the features we have in our model. And that's in training, and in test set, you can see you'll always have a drop within the respect of your validation study. So it's a 0.68 for the image only model and a 0.71 because the clinical features aren't changing. So you see that you have this incremental improvement of utilization of AI features, this AI grading approach, we call it, which is actually influencing and supporting the clinical features to be able to predict a more accurate level of recurrence and risk. And one thing I'd like to share is that, when I went through in that first slide of looking at the clinical features that are important, so it's age, stage, tumor size, and lymph node status. Grade and ER status, all of those other variables were part of what the model could actually select. It did not select histologic grade as a relevant feature. It actually selected the features that are present from the imaging side in the context of those other clinical variables. So it illustrates that competition that goes on when you develop these kinds of models, that the image features themselves are competing with the assigned histologic grade that the individual patient has based on the pathologist. So it reinforces some of what trying to drive forward with is this standardization and accuracy. And as you can see, we're just visualizing what those AUC curves on the bottom. And now you take that model and then you really stratify it. And this is really a process where you go through to identify a threshold. So, and this is more from clinical use case, as well as demonstrating that ability to separate out low and high risk patients based on their outcome and sort of a traditional Kaplan-Meier. And so going through that process of identifying a threshold, optimizing it to sensitivity and specificity to get to the best threshold that would separate those patients. And as you can see, both in the training and test set, we're very effective in being able to identify that threshold. And then you can see the hazard ratio there of 5.2 and then 4.43 in the test set model are quite strong with regards to that separation. So you can use this as a tool to help sort of reinforce and how you could implement this in a clinical environment. And the bottom of this slide gets into some of the detail that I wanted to share, and I'll show you a little bit more about that importance of being able to differentiate grade. And I think that's one of the variables that we all know has come in and out of favor in the pathology world because of subjectivity associated with grading. So if you look on this in the NGS, that's the Nottingham grading system grade 2, and there were 868 patients of the 2,075. So 41% of the patients, as I shared, had grade 2 disease. And then if you look at those patients in the context of the full model, which is imaging and clinical, or just the AI grade, which is just the imaging features, we redistribute the actual grade of the grade 2 into high or low risk. And you see the full model, so 78% of the patients fall into the low risk category by grade, and that's AI grade, and the PDX high risk group, 22%. So that's that taking grade 2 and redistributing it into a low and high risk. You can do that just with imaging features alone and separate them out by 80% low and 20% high. So sort of what you would expect in the breast cancer early stage disease of those patients most likely to progress, you're getting agreement with regards to the AI grading approach. So it's sort of supportive for us to see those kinds of elements. And it does bear in mind that view that many oncologists have, and I think a lot of pathologists as well, that grade 2 is really a hybrid of grade 1 and grade 3. And so you're seeing this ability to be able to distribute them in a much more effective way that can standardizable. So you just would run the model and you can actually do that. And on the next slide. And we did do that and compared which is a way to look at both histologic grade and AI grade from an AUC or C-index perspective. I think we all understand that AUC grades for the majority, obviously from histology grade, are not very prognostic. So they're about 0.61, 0.62 overall. Whereas if you start using AI grade element and comparing it, you can see what I shared on the original table there. You get this improvement when you introduce imaging features into that, and you can see the CIs on the bottom of the screen there, that it is obviously superior visually as well as mathematically, that the AI grade is actually adding a whole nother level of understanding of grade, because as Jerry went through, the different types of features you evaluate that are not in our traditional grading of breast cancer. So things like stromal content and lymphocytic infiltrates are not part of our grading systems today in breast. So this allows you to see that importance of that and that differential from just comparing it to just our traditional histologic grade. Now the next slide. So, and obviously we did some internal studies because this is something that is one of contention to some degree of how do you actually represent this. And some of this was more for New York State because you're demonstrating to non-pathologists of why this is an important piece. And just looking at this from a kappa perspective and a set of cases from a breast pathologist and 2 surgical pathologists who see a lot of breast cases, and then getting a sense of what does that look like between themselves as well as between each other with regards to what are our traditional measures of grade, and using mitotic count or tubule scores or nuclear pleomorphism, which gives you your classical grade, you can see the kappas are not very good. And so and some pathologists did very well. The breast pathologists did okay, but quite surprising to them that they weren't really in agreement even with themselves, and there was a washout period. And this is this kind of material that's been published for quite a while. It continues to be evaluated within the context of institutions, as well as reports more from understanding of the impact of what this means with regards to that challenge. But as you can see, this is a subjective approach, and it can be borne out by just the ability to be able to understand and influence your own decision making with them. That's why you have washout periods with folks to do this. So this just emphasizes that challenge from a pathologist perspective of overall grading. And then also looked at this in the context of what are clinical models. So there's many that are out there that can be used, and these are population-based models. So I always caution, because we all do that you compare to an optimized model, which is population-based, not truly reflective of your cohort. But we did it because obviously we work with some folks in this space on different genomic strategies that are using these tools. And this is what was in the MAMA print, and it's also part of the RS-Clin studies for Oncotype to use estrogen receptor status, HER2 status, nodal status, and tumor size. So not all of them use the same features. There's lots of overlap to some, but this is the way they pull it into an understanding of clinical risk. And this is from the MAMA print study that was in New England Journal, which is now used because Adjuvant Online is no longer online. And so you can see the blue line is that's the MINDAC, the MAMA print assessment of this cohort, and then compared to the clinical full model that I shared of clinical and imaging data. So again, there's that continued evidence that supports this ability to be able to use the image analysis approaches of grading from a standardized perspective, elevating phenotype, and then combining that with well-known clinical factors is quite powerful. And then the next slide, Jerry. And so in addition to that, the population that I shared of this early stage disease, there was a subset of patients that all had Oncotype data and all had outcome associated with them. And as you probably know, there's not a tremendous number of studies that have looked at outcome in the context of the general population that's having Oncotype. And so this was an ability for us. It was 600 patients, 599 total, that all had Oncotype data. We had outcome data on all these folks. And then we evaluated in that context of how well did the Oncotype do within that setting. And as you can see in the table, and it's a busy sort of AUC, and this is all published as well, but we were looking at that importance of adding different variables to Oncotype. And so Oncotype alone, you can see 0.35 from a CI, Oncotype plus histologic grade. So that's the grade that was assigned to that case, 0.51, Oncotype plus clinical, 0.64, Oncotype plus AI grade. So that's just an imaging model, brings it up to a 0.72. So that's the biggest bump that you'll see in the context of Oncotype. And then if you add the clinical features that are full model to that, now you're getting up to a 0.76 in a CI. So very strong indicators that importance of clinical data, which incorporates a very quantitative AI grade phenotyping, is relevant with regards to that precision piece. And this obviously, this kind of an approach supports sort of what the RS-Clin studies, those that follow sort of the Oncotype world, both within the context of TaylorRx and how it can be implemented in practice, that there's a lot of support and need for using these kinds of activities of clinical data in the context of genomic stratification of patients to make it more precise, to make it much more reflective of you're actually looking at something that's relevant for that individual patient. And that's what this supports. And obviously it was for 600 patients. For us, we're now obviously going after a variety of cohorts that have Oncotype plus outcome data available that we could then reinforce and understand our this ability to introduce AI grading approaches in that context. And talking to the developers of Oncotype, and actually one of the oncologists is actually at Mount Sinai, Joe Sperano. There's a lot of interest in using tools that will standardize these kinds of approaches to quantify and allow individual elements such as grade back into the process of understanding and make that more accessible outside of just major healthcare systems where you have two breast pathologists that may be completely concordant to some degree, but making these kinds of strategies more appropriate for a larger, broader oncotype population. And this is not just for oncotype, but obviously there's other genomic strategies that have all incorporated clinical data. MammaPrint has, EndoPredict has. They all see the value of this, and this illustrates it at a level now that you can do it from a digital image and combine that with clinical data, and then use that in the context of oncotype. And so I think, Jerry, did you want to go through this, or do you want me to?
Well, I think this is the last slide. This is just an example of the report that we've generated. We're also working on on something that can be accessed online that would give you a deeper dive into the individual features, which I think will be something that will be very useful for both discussing with the patients and the oncologists the results and figuring out how to interpret the results. But this is just an example of, with the low risk and the high risk on a scale here, and then just a brief description of what the features are, what features are pushing the model in whichever direction that it's going in. I don't know if there's anything else.
Just to illustrate that, I think from showing this to oncologists as well as to patients, you get a sense of that, trying to make it as easy to understand as possible from a laboratory developed testing perspective and understanding risk. And those are elements that are not usually easily adaptable, but it tried to reinforce that from a visual perspective. Pathologists, at least, it's evolving into having more and more digital reports that are available with images to have folks understand what it is that you're actually measuring from not only just the pathologist specialty, but from the oncologist as well. And so that helps to reinforce that. And behind this, the underpinnings of what Jerry mentioned is the whole analytic validation strategies that require that you be able to have precision and repeatability and reproducibility to be able to actually generate these types of clinical reports and to get that into the hands of both the patient as well as the oncologist. So it's a way to actually illustrate that and use the digital space to actually do that in. So I think that's it. So I know we went a little over, so we apologize, John. I know that
no apologies necessary.
45 minutes. So
you guys gave the exact type of talk that we want, and I really appreciate it. And so thank you very much for a great talk.
Good.
I have a lot of questions.
Yeah, I figure.
I have a lot of questions, and so do other people, I'm sure. But before we do that, can you just describe what the clinical flow is for using PreciseDx? I think you mentioned on your website that you take your slides as normal and you send them for processing, I guess, to your local pathologist, and then your local pathologist uses this tool.
So the usual ordering physician is the oncologist, and so right now we are approved in. The New York State approval requires that we receive a glass slide. So we would do the scanning in our laboratory and generate a report. The report would then populate the patient's chart, go to the oncologist, and a copy would probably go to the pathologist as well. So, in this first phase that we're launching this test, the test is really intended to support or to add value to the decision-making process with the patient and the oncologist. Obviously, the features that we're generating should be of great interest to pathologists as well. And we are, we're sort of toying with the idea of how do we present this and give some utility back to the pathologist, because our turnaround time is really a matter of hours. I mean, we could turn a test around in a day if we had already the scan. And so, it could be something that could be inserted into the pathologist's workflow as well. But currently, the test is really aimed at providing information to the oncologist.
Great, thank you. Just raise your hand if you have a question, or if we don't, if they're coming slowly, just go ahead and ask. Do we have any other questions from the audience?
Can I ask a question?
Yes. Please introduce yourself and where you're from as well.
Thank you. My name is Saad Nadeem, and I'm an assistant professor at Memorial Sloan Kettering Cancer Center. We work a lot in computational pathology, surgery, and radiology space. So now, following the approval from New York State LDT, what's your plan to, is there a plan in place to reimburse for this via some established CPT code? Or how are you going to kind of create like a revenue stream for your institution, or, you know, in general?
Great question. So we got a CPT code back in 2020 for the surgical resection specimen for breast. And the part of that process then is we went through a gap fill process, which is what the CLFS groups make you go through if they can't crosswalk to something that already exists. And there was no predicate device for us to crosswalk to in this space. So we did go through the gap fill process. We have a price. And so now we're actually in the process of putting together dossiers, which you need to go through to the various MACs in the United States. And we have obviously a lab that's located in New York, and we also have a lab that's in Florida, which covers, we're a New York State approved test. That part of the strategy really is to look at this from a variety of perspectives geographically of where to go through, because part of your necessity is to demonstrate both from a clinical, analytical, as well as use case scenario for the ability to have reimbursement and coverage to be, you know, so that's our process that we're going through right now to, you know, really strategize that from a dossier of what is necessary to be able to move it through that reimbursement process.
And sorry, just one question. So will this be easier now that you have it from New York State? And I think that's the toughest state, they say, to be able to replicate this into the state.
Right. So New York State, obviously, that's part of your ability to have a clinical test within the state of New York. And you know, not all states function the same. So New York State has their process, which is very similar to what would be a very high regulatory space. The MAC that's associated with the New York region is independent of the state. So you have to have that first, and then you'd be able to use the test. And then we're in the process of actually working with various folks. Maybe we could work with you at Memorial to look at this from a clinical utility decision support study to understand the decision piece, how this would be used in clinical practice, both from a pathologist as well as from an oncologist perspective. So that's what we're doing currently in addition to what I just shared with regards to that reimbursement strategy.
So Michael and Geraldo, I was really, it's quite impressive the results you had in the Grand Challenge. And I presume most of your challengers might have used non-informed AI, where they were just guessing the outcomes without the intermediate morphology. So I would interpret that as this intermediate step was important to the success of your model. But in some ways, your model might be considered a ideal human model versus a superhuman model, right? Because you're constraining the AI to morphology features that you already feel are important for survival. So can you illuminate that a little bit? Like, for example, I would think your model might, if you had 1,000 pathologists that were scoring, the perfection of their reads would improve and potentially match that of the AI and give you potentially the same performance if you fed those results through a support vector model like you did. So can you comment on that versus the peak human versus superhuman performance of your model?
Well, I would say, and I think Jack is on the call too. He can chime in if he wants. But I would say to that you know, superhuman is also a reproducible human. So you know, it is superhuman in the sense that that you'll get the same results every time. And as we showed in our in the little mini study that we conducted internally for reproducibility across different pathologists and amongst themselves, the performance was really quite bad, and that's been shown many times over and over again. So we restrict ourselves to recognized features, or features that are at least explainable by recognized parameters for prognosis. Largely because we want to stay away from overfitting and also for basically clinical acceptance. So I don't know whether your statement about 1,000 pathologists would hold up if it was a consensus, I guess, amongst 1,000 pathologists.
Let me just jump in. I don't think a lot of them wouldn't be practical to be done. So while a human can recognize a mitotic figure, the AI is counting all the mitotic figures on the slide and determining the actual area of highest density, or with lymphocytes, determining areas of density. So it's not, it's, even if you had 1,000 humans, it's not practical to ask them count every mitotic figure on the slide and don't tell me where you think the area of highest density is actually calculated. It's not, they couldn't do a comparable calculation. They could maybe, sort of eyeball it, but the way things are calculated, there's not a directly practical human analogy for a lot of these. So you could recognize the output and say, yes, that's a mitotic figure. Yes, I see, this is a dense area. But, for a human to actually go and find the area of, high lymphocytic, the actual area, and quantify it, in most cases isn't practical.
Right. Okay. Thank you. Dan, you had a question?
Yeah, thanks. Great talk. Wondering about tissue area requirements. In particular, would a core biopsy provide sufficient tissue for this assessment?
Yeah. So we actually have. So phase 2 is the same model on biopsy tissue. So we just received a CPT code for the biopsy model and are in the process of undergoing our analytic validation studies to validate that model as well. So we do have minimum tissue requirements, which are quite small. I'm blanking right now on the exact area, but I think it's about 2 millimeters of tissue. When we go down to as low as, if anything above 2 millimeters or above of tissue, we're able to generate a reliable model. And once we go below that, it starts to fall apart a little bit.
Great, thank you.
That doesn't have to be continuous, actually. It could be in fragments.
Any other questions?
Jerry, I have a question. Can you hear me?
Yeah.
Yes.
So this is the first time I've seen this report that the oncologist gets and the patient gets. And I'm wondering, is it just one page? Is this the complete report that they get?
Yeah.
Just one page right now. Correct. Yep.
So, can I just give you feedback from about the Oncotype test? Okay, so I think it's really helpful for patients when they get their these reports and they really like lots of information. And on the Oncotype DX test, they actually have a page and it says absolute benefit of chemotherapy. And there's all this information that helps the patient decide if they want, the patient and the oncologist together decide if they want chemotherapy. Are you planning on having that?
Yeah. So
this is the prototype, sort of a single page test to make it accessible, but certainly doing those kinds of approaches to enhance the ability to be able to translate this into something that's practical are underway. Just not yet today, but so we're moving in that direction like others. The challenge always with multiple pages, as you probably know, is that if it's faxed, you'll get the one and you'll never see the others. And in Epic and electronic health record systems, it's sometimes challenging because it has to be a PDF that's not part of the patient's report. So there's some complexity with multiple testing, but I love, Oncotype and others that have used that supportive materials. And that's something we're developing right now.
I just want to give you a woman's back. So I got the Oncotype text 20 years ago or more. I got it the first year it came out, and I've read that test so many times, and it has 5 pages, and it it was an important thing for me to have that.
Awesome.
So even I'm just as from a, and I've talked to, I have so many dozens of friends who've had breast cancer, and we would prefer more information than less. So if you're thinking of just putting it on one page because it's making it easier for us, we want more information. So, you know, and also for women to understand the risk. They I talked to my oncologist about it a lot, and he loved it too. So I think that is good feedback to get from women. Oh, and another thing is on your example test, I think it'd be nice, instead of showing high risk, show low risk. So it just, I mean, you know, as an example, do you see what I'm saying? Here you're choosing to show what it's like, but I think psychologically it would be better if you showed a test that showed low risk recurrence.
Point.
point.
Thank you.
So, Margareta, I alluded to this. One thing that we're trying to do is develop and we have a prototype that we really just can't show just yet, but a deeper dive into the results, which would be an online report, which would leverage the imaging that you get on the web. And it would show a breakdown of the different features and where those features lie on a scale. So you could really focus in on what are the features that are driving the individual patient's score. And so there's another version of this report, which is electronic, that goes much deeper in and looking under the hood of the model and looking at the different components that are driving the actual score. So we agree with you 100%. It's just that from a, some of the feedback, your feedback is greatly appreciated, but oncologists will often say, if it's not on one page, I'm not going to read it. So, like there's sort of that counterbalance that we have to deal with. So we're trying to deal with it by providing a suite, a deep dive suite that allows patients and oncologists or pathologists to dive deeper under the hood. And then there's, maybe a lesser version that would be faxed to the clinician.
It's sort of funny that the oncologist wants less information and the women want more information. It's funny. But I have one more question. So you know how I wrote the article about, your paper? The question I was asked the most, I got hundreds of messages asking if people can submit their pathology from out of state and from different countries. Like, I know it was approved in New York, but people were saying, can people send in their digital slides or from other states and from other countries to your pathology lab?
So definitely from other states. So we have the approval in, I think, 49 states right now. With one. So we're out there in terms of the accessibility for the United States. And for Europe, it would just be a discussion sort of with that individual country. It's not a problem because, even clinical departments get material from Europe, Asia, South America. So there's no reason.
Good. So I didn't write that in my article. So a lot of people, because I didn't know. So a lot of people were asking, and it was really, over 25,000. Pardon?
It's an evolving process for us because we're just getting the approval through all the states, so that takes some time.
Please don't say the state is.
Over 25,000 people read that article, and there were 500 likes, and that was a really. So what you did caused a lot of conversation, and people were really excited by your paper.
Wow, that's good to hear. Thank you.
Yeah. Please don't say the one state is Hawaii. That is the holdout.
No, it's not.
Okay, good. Well, we're a little over time. I have follow-up questions, and I'm sure that Geraldo and Michael would love to get your questions as well. You can either send them to us or directly to them, and we'll close out this session. I appreciate everybody attending. Our next session, of course, is on August 4th, I think it was, and I hope to see everybody there. Please spread the word about these Affinity meetings. And thank you very much for attending.
Thank you.
Thanks, John.
Thank you.